The Subcommittee on Information Technology and the Subcommittee on Healthcare Benefits and Administrative Rules will come to order. Without objection, the chair is authorized to declare a recess at any time. We're expecting votes fairly soon, so I'm hoping that we can get through opening remarks, go do our vote series, and come back and finish the hearing. Good afternoon. Appreciate y'all being here today. Y'all know, y'all are in this space, that heart disease is the leading cause of death in the United States, according to the CDC. More than 600,000 Americans die from heart disease each year. The American Medical Association recommends walking as the simplest positive change you can make to improve your heart health. Walking 30 minutes a day, or around 10,000 steps, lowers blood pressure, improves mood and mobility, and increases energy. Simply increasing the number of steps you take per day can significantly reduce your risk of coronary heart disease and stroke. Many of you could glance right now at your smartphones, wearables, or other devices and report your number of steps and calories burned for the same periods of time. And for most of us, I'll bet that number is probably higher than before we had the app or device and we were tracking our steps. It would not be an extreme exaggeration to say that the proliferation of wearable devices and smartphone apps that track steps and the accompanying increases in the number of steps some people are taking on a daily basis has saved lives. This is just one example of the benefits technology has brought to health and healthcare, and we have barely scratched the surface. We are on the cusp of being able to use technology to truly revolutionize healthcare and healthcare delivery. Leveraging the power of the cloud will enable us to move more healthcare tasks online, including consultations and data storage and retrieval. Sensors will make it easier for people to take care of themselves before they get sick. Constituents in rural parts of Texas 23rd, my district, will be able to speak directly with their primary care providers instead of commuting hours each way. As more devices are connected and more data is generated, medicine will become customized and personalized. Preventative medicine and healthy living practices will increase, costs will decline, and the prevalence of chronic diseases will decrease substantially. But this will only happen if researchers, hospitals, entrepreneurs, regulators, healthcare professionals, patient advocates, and lawmakers come together to update antiquated laws and reform outdated institutions. Right now, old and unclear privacy laws hinder interoperability between health IT systems and devices. Right now, the sheer number of federal agencies and often conflicting rules one must navigate to invest in this space chills investment and entrepreneurship. And right now, a fragmented and bureaucratic system places the patient at the fringe of the process rather than at the center. In today's hearing, I hope to hear specifically what laws or regulations need to be changed or updated and how they should be changed or updated or abandoned. Health IT is an exciting, innovative field. But to get this right, we must collaborate, we must destroy silos. I'm committed to doing so. I know my friend and ranking member, Ms. Kelly, and Ted Liu is as well, and I want to thank the witnesses for being here today, and I look forward to their testimonies. And now I'd like to recognize Mr. Cartwright for his opening statement.
Thank you, Chairman Hurd, and I'd like to thank you both for calling this hearing so we can hear about how the federal government and private industry are working together, and for your interest and efforts at creating the next generation of health information technology. I represent largely a rural district in northeastern Pennsylvania, and I know quite well how health IT can bring affordable medical care to those who might not otherwise be able to receive it. In fact, that's why I co-sponsored the Medicare Telehealth Parity Act of 2015, the 21st Century Cures Act, and also the Telemed Act. Bills like these help medical professionals provide patients with the best health care available anywhere and at any time. But even with the undeniable benefits technology brings, patient safety must remain our foremost consideration. Technology brings opportunity, but it can also bring unforeseen challenges, and I hope we can talk about that a little today. As a career courtroom attorney, I have seen too many medical malpractice lawsuits where carelessness caused injuries and death, and where doctors have made grave and avoidable mistakes, and too often these mistakes were due to failures in communication that left physicians and nurses without all of the patient's information that they needed to complete proper assessment and treatment. We worry that different computer systems, standards, and methods of tracking medical history often mean doctors, nurses, lab technicians, and others involved in the treatment process cannot get a complete understanding of the illness in front of them and the treatment that's needed. That's why it is so important that technologies like electronic health records, which contain the complete medical and treatment history of a patient, quickly and efficiently give providers insight and a comprehensive view into what's going on and all of the facts of the case. Standardized, industry-accepted technologies can make that happen, in my view. In the field of health IT, private industry has a critical role in the process, doing what it does best, drive innovation, and keep America at the leading edge in medical technology. The federal government also has a role to play, making sure these new technologies meet healthcare needs without compromising patient safety. I'm looking forward to today's hearing, to the testimony of all of you. I'm glad that industry and government are working together to bring about the kinds of technological advances that will improve healthcare in this country, make it safer, and make it more available to people in all corners and all pockets of this nation. I thank you again, Chairman Hurd, and I yield back.
Thank you, and I'm going to hold the record open for 5 legislative days for any members who would like to submit a written statement. And Ranking Member Liu is here, and if he is ready, we'll have him give his opening remarks. Mr. Liu from California is recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you to the witnesses who will be presenting today. Today, we're here to learn more about how to make the primary health technology laws work smarter and better. Laws and regulations should be there to protect the public, but done incorrectly, they can hinder innovation, and the same holds true in the health IT space. The Healthcare Insurance Portability and Accountability Act, HIPAA, contains provisions to create universal electronic medical records and protect patient privacy. The Health Information Technology for Economic and Clinical Health Act, HITECH, contains provisions to protect consumer privacy and give notice in cases of data breach. The Affordable Care Act also contains provisions to improve the quality and efficiency of patient care with ECRs. However, these laws and regulations were enacted before key technological advances that we now take for granted. HIPAA was passed in 1996 before broad adoption of the mobile revolution. HITECH was passed in 2009 before much of cloud computing existed. Some might suggest that rolling back regulation is the answer, and while I agree that government regulation is not as nimble as technology, we still need some combination of regulations and enforceable guidance to protect the public. For instance, last month, the IT system at Hollywood Presbyterian Hospital in Southern California was held hostage by ransomware denying patients and providers access to their medical records. The HITECH law has cybersecurity requirements and requires notification for data breaches, but the law says nothing about notification for data that was frozen or held hostage where it is stored. I note that today, press reports that 2 more hospitals in Southern California were hit with malware attacks. Technology has moved very quickly. Telemedicine, text messaging, and the mobile smartphone explosion requires that HHS and FTC keep up with technology changes, update guidance reliably, and keep rules and regulations flexible to encourage innovation. Regulation done wrong or too little regulation makes it difficult to protect the public and ensure that data flows freely. Regulations done right spurs innovation, improves quality of care, and protects the public. I look forward to hearing from the witnesses today about what we can do to encourage innovation and cooperation and continue to bring government and healthcare into a more modern era of service. And with that, I yield back.
Thank you, Mr. Liu. And if Chairman Jordan joins us and is interested in giving opening remarks, we'll let him do that as he arrives. Again, I'd like to thank the witnesses, and I'd like to recognize y'all now. I'm pleased to welcome Dr. Karen DeSalvo, National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services. Thank you for being here. Ms. Jessica Rich, Director of the Bureau of Consumer Protection at the U.S. Federal Trade Commission. Mr. Matthew Quinn, Federal Managing Director at Intel Healthcare and Life Sciences. Mr. Neil DeCrane, did I say that? Crescenzo, member of the Executive Committee at the Healthcare Leadership Council, and Mr. Mark Savage, Director of Health, IT Policy and Programs at the National Partnership for Women and Families. Welcome to you all, and pursuant to committee rules, all witnesses will be sworn in before you testify. Please rise and raise your right hands, please. Do you solemnly swear or affirm that the testimony you are about to give will be the truth, the whole truth, and nothing but the truth? Thank you. Please be seated. And let the record reflect that the witnesses answered in the affirmative. In order to allow time for discussion, please limit your testimony to 5 minutes. Your entire written statement will be part of the record. And we're going to go through as many opening remarks as we can before we get called to votes. If the bells go off while you're in your remarks, go ahead and continue, and we'll finish after your remarks. And now, I would like to recognize Ms. DeSalvo for your opening remarks.
Thank you, Chairman Hurd, and Ranking Members Liu and Cartwright, and distinguished members of the subcommittees. Thank you all for the opportunity to appear here today. I am Dr. Karen DeSalvo, and I have the honor of serving as the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services for the past 2 years. I'm proud to be here today representing the remarkable team at the Office of the National Coordinator and share with you the current state of health information technology in our nation and how we're working with others to see that these systems realize their full potential. The Office of the National Coordinator for Health Information Technology has a strong bipartisan history. It was established in 2004 by executive order and charged with the mission of giving every American access to their electronic health information. In 2009, it was statutorily established by the Health Information Technology for Economic and Clinical Health Act, or HITECH, which provided the resources and infrastructure needed to foster the rapid nationwide adoption and use of health IT. In the 7 years since HITECH was enacted, we've seen dramatic progress. Today, nearly all hospitals and more than 3/4 of physicians report using a certified electronic health record. This tripling in rates of adoption puts us as a nation well ahead of our peer countries, giving us significant competitive advantage in healthcare, innovation, and scientific advancement. And it is working in so many communities across this country. But I also know that we haven't realized the full potential of health IT for every person in this country. And this is not just an abstract policy idea to me, it is personal. It's why I came to ONC 2 years ago, because I knew as a doctor the promise of health IT, of having information available for me when I was on call in the evening, not at the hospital. Such a leap from the days in the early 90s when I was a medical student at Charity Hospital and had to physically go up to a lab and pull a lab slip with handwritten results from a wooden box so that I would understand more about my patients and how to care for them. Today, that's all available electronically to me and other doctors, and not just to us, but to our patients, to really see that they can be empowered and have the information they need to self-care. It's a rapid and remarkable transformation in a very short period of time. But the pace has come with challenges. Like others, I have been frustrated by the lack of interoperability, by the usability of the systems, and by how hard it can be to select the right system to buy. I hear about these challenges from my colleagues, whether in listening sessions, but also from consumers and other stakeholders. We all want to move ahead with the technology, but we want it to work better, and that's what I came to Washington to do. Since I've been the national coordinator, we have been focused on fixing those challenges in an urgent fashion to meet the expectations of the people that I serve, the American people. ONC does this in a variety of ways. For example, we can leverage our electronic health record certification program. We also serve as a coordinator across the federal government to see that agencies have shared policy and technology approaches and will send clear signals to the private sector. We've also worked with the private sector on setting a clear path ahead for our nationwide interoperability. This roadmap that we produced last year lays out who should do what by when to achieve interoperability in the near term to see that electronic health information is available when and where it matters to consumers and clinicians. ONC and others have been meeting our deliverables from this plan and are advancing drivers of interoperability like payment reform, publishing clear standards, working with states and others on harmonizing privacy and security expectation. The plan has been publicly endorsed by our federal partners, by the private sector, and we've been so pleased with everyone's willingness to step up and lead where appropriate to see that we can innovate and accelerate interoperability. Indeed, working with the private sector is how ONC operates. As another example, we recently convened stakeholders to ask them to make a series of commitments to ensure that electronic health information works better for patients and providers. It's a really tremendous opportunity for the private sector to lead. And so last month, we were able to announce that companies that provide electronic health records for 90% of hospitals in this country and healthcare systems with facilities in 46 states, including the states for all of the members of these two subcommittees, and over a dozen professional associations and stakeholder groups like the AMA and the American Hospital Association, all have agreed to implement 3 commitments that will help make sure health information flows. The commitments are that consumers will have access to their electronic health information, that entities will not engage in health information blocking, and that we will move to federally recognized national standards so that all these different systems will speak the same language. ONC and our partners in the federal space and the private sector are working together each and every day to see that we can move this future vision to an immediate reality. And Congress has been one of the great partners in health IT, and I look forward to continuing to work with you all to realize the full potential of health IT for this country. Thank you for having me here today, and I look forward to your questions.
Thank you, Dr. DeSalvo. Now, Ms. Rich, you're recognized for 5 minutes.
Chairman Hurd, Ranking Members Liu and Cartwright, and members of the subcommittees. I'm Jessica Rich, Director of the Bureau of Consumer Protection at the Federal Trade Commission. I appreciate this opportunity to present the Commission's testimony. Consumers are increasingly taking an active role in managing their health data, and there's been an explosion of new products and services to help them. These range from wearable fitness devices like Fitbit or Jawbone, to dieting apps like MyFitnessPal and Calorie Counter, and to websites like WebMD, where consumers can get health advice and information. These products and services offer enormous benefits to consumers, but they raise privacy and security concerns too. Who has access to all of this data, and is it being stored securely? Much of this activity now happens outside the doctor's office and other traditional healthcare contexts. As a result, it's not protected under HIPAA, which only applies to health data held or generated by covered entities, such as healthcare providers and health plans. In most instances, however, this activity is covered by the Federal Trade Commission Act, which prohibits unfair or deceptive practices across the marketplace, including in the area of health privacy. As the primary federal agency charged with protecting consumer privacy, the FTC has made it a priority to protect consumer-sensitive health information. Our efforts include civil law enforcement, policy initiatives, and consumer and business education. 3 recent FTC cases illustrate the challenges we faced in protecting consumers' health data and how the FTC is addressing them. PaymentsMD is a medical billing company that offered an online portal where consumers could pay their bills. The FTC charged that the company misled thousands of consumers who signed up by failing to tell them that it would also seek their highly detailed medical data from pharmacies, medical labs, and insurance companies. Henry Schein provided office equipment software for dental practices. We charged this company with misrepresenting to clients that its software provided industry-standard encryption of sensitive patient information as required by HIPAA. In fact, we alleged the software used a weaker method of data masking that didn't meet HIPAA standards. A third example is our settlement with GMR, a medical transcription service. We charged that GMR assured its clients that its services were secure, but outsourced them to a third party service provider without adequately checking its security measures. As a result, consumers found doctors' notes of their physical examinations freely available on the internet. Besides enforcement, the Commission engages in policy initiatives to encourage stronger protections for health information. Last year, we hosted a public workshop on consumer health data to examine the products and services consumers are using to generate and control their data and how this data is protected. We also released a staff report on the Internet of Things, which, among other topics, examined the privacy and security issues raised by connected medical devices and health and fitness products. Of greatest concern, panelists discussed the unique risks if health devices like pacemakers and insulin pumps are not secure and vulnerable to hackers. Finally, the Commission promotes stronger data protections through consumer education and business guidance. For example, our new identitytheft.gov website provides customized advice to consumers who have been victims of medical identity theft. And last year, the FTC launched its Start With Security campaign to educate small businesses around the country about how to develop an effective data security program. In addition, working with HHS and with FDA, the FTC is currently developing business guidance for health app developers to help them understand which legal requirements apply to them. The FTC shares the subcommittee's concerns about the need to protect the privacy and security of consumers' health data. Although we now use a variety of tools to protect consumers in this area, additional tools would enhance our ability to do so. To this end, the Commission reiterates its longstanding bipartisan call for federal data security and breach legislation that would allow us to seek civil penalties to deter unlawful conduct and give us jurisdiction over nonprofit entities. In closing, the FTC remains committed to protecting consumer health data and looks forward to our continued work with Congress on this critical issue. Thanks again for the opportunity to provide the Commission's views today.
Thank you, Ms. Rich. Mr. Quinn, you're recognized now for 5 minutes.
Good afternoon, Chairman Hurd and other esteemed members of the House Oversight and Government Reform Committee. Thank you for the opportunity to testify today on behalf of Intel Corporation. In my written testimony, I provide some tangible examples of how Intel is working to make good on the promise of today's health technologies and to pave the way toward tomorrow's. Today, I'd like to frame my comments in the context of recent personal experiences. 2 Fridays ago, I received the call that no one wants. My sister in Ohio said that Dad had just taken a bad fall. He had just left his doctor's office, where he was in for a checkup after a recent hospitalization. Things had gone well, and they stopped by a favorite restaurant for breakfast. As my dad climbed the curb, he became lightheaded, fell to the ground, and tumbled back into the parking lot. As we soon found out, he broke his clavicle, pelvis, and deeply cut his elbow. To say that my dad is a complex patient would be an understatement. He's the poster child for needing all of his providers and caregivers to be on the same sheet of music and to have the whole picture of his health and health care. Let's begin by thinking of the constellation of my dad's health data. Most familiar are the clinical and claims data captured at clinics, hospitals, and the like. Secondly, there is diagnostic data captured by medical devices and imaging. Adding to this is consumer-generated data. And finally, there is omics, vast amounts of information in his genome. Personal precision medicine in the 21st century will need to make sense of all of this. The U.S. has made great strides to ensure that each person has an electronic health record, yet the goal of point-of-care and personal access to comprehensive health information has not yet been achieved. There are 3 recurring barriers that often limit data sharing. First, medical institutions using privacy and security policies and laws like HIPAA as excuses for why they can't share. Next, medical professionals lacking easy, affordable tools to share data, especially because vendors fail to use or consistently implement standards. And finally, payment reforms that don't reimburse for new care models like telehealth. Back to my dad's experience. When he arrived at the ER of the same hospital where he had received his most recent treatment, they pieced together his health history, partly from the EHR and partly from my parents. I fear that if he was brought to a different hospital, it would have been basically starting from scratch. There exists a local health information exchange, but evidently, this hospital and my dad's nephrologist don't participate. My mom is our de facto health information exchange. My dad would definitely enjoy the kind of secure, standards-based data sharing that Intel's own Connected Care program makes available for over 33,000 of its employees. As we've shown, it's all quite possible today, just not widespread as it could be. We need to think about interoperability in much broader terms than merely the exchange of electronic health record data. That will change as the Internet of Things takes hold and we connect smart devices to the Internet in ways that generate data that can be turned into valuable insights. How would this affect my dad? Well, first of all, it would allow him to get some sleep. Because the devices monitoring him in the ICU don't talk to each other and his vitals tend to bounce around, there are endless, nearly always false alarms. What if devices, even from different vendors, could talk to each other? Innovators could create smart alarms from the new combined data streams and save countless hours of nursing time, countless lives, and just let my dad sleep. The data from all the medical devices could automatically feed the EHR, millions more nursing hours saved. But let's think bigger. What if when my dad was discharged that he was outfitted with sensors or an app that constantly detected whether his gait was making him prone to falls? Or what if, instead of having to drive across town to visit his doctor, he could do so from his home via telemedicine, and his blood and vitals could be automatically analyzed via his home dialysis unit? What if his caregivers could track his progress in getting back up on his feet as he rehabs? I think we've come up with half a dozen ideas for new businesses, but all of this relies on there being a solid foundation for the Internet of Things to blossom. Security from the sensor to the cloud, connectivity allowing devices to communicate their status to the system, data normalization to allow devices to speak the same language, and actionable analytics. So to close, how do we believe Congress can help seize the opportunities and overcome the challenges? First, sustain momentum towards standards and interoperability for today and for tomorrow. As Intel's Connected Care program demonstrates, a rigorous, standard-based approach enables quicker and more rapid, efficient deployments today. And to rapidly move forward toward the Internet of Things, Intel invites active federal participation in industry-led initiatives such as the IIC, OCF, ICE Alliance, and Continua. Second, encourage patient engagement by removing obstacles for patients to access and share their data. Intel invites policymakers to partner with industry to pursue a standardized machine-readable consent form to allow patients to easily donate their data to ongoing research. And last but not least, continue to push toward value-based care. We support the HHS goal to move half of care to alternative payment models by 2018. When incentives are aligned toward value-based care, the demand for information sharing goes up. Congress can further drive innovation by providing reimbursement for remote patient monitoring and other promising technologies. Thank you, and I look forward to your questions.
Mr. Quinn, appreciate your opening remarks. Now, Mr. DeCrane is recognized for 5 minutes.
Thank you, Mr. Chairman. Members of the committee, it is a privilege to be here today. My name is Neil DeCrane. I'm the President and CEO of Change Healthcare. Perhaps our name says it all. Change Healthcare is headquartered in Nashville, Tennessee, provides its services in all 50 states, and has over 50 offices nationwide. We are a leading provider of software and analytics, network solutions, and technology-enabled services that optimize communications, payments, actionable insights that enable smarter healthcare. By leveraging our intelligent healthcare network, which is one of the largest financial and administrative networks in the United States healthcare system, payers, providers, and pharmacies are able to more effectively manage complex workflows that support value-based healthcare. While I'm proud to represent the nearly 7,000 people of Change Healthcare, I am testifying today in my role as a member of the Executive Committee of the Healthcare Leadership Council, a coalition of leading companies and organizations from virtually every sector of American healthcare. In that role, I would like to share a few thoughts on the role and capability of health information technology to transform our nation's healthcare system for the better. As is increasingly the case in most fields, healthcare improvement today is driven by data. And if our healthcare system is not improving at the pace any of us would like, this is, in large part, due to barriers standing in the way of access to data, the ability to share information, and the utility of this information for consumers, providers, payers across the healthcare continuum. Our HLC member companies know from firsthand experience that data interoperability can strengthen care coordination, enabling providers, payers, pharmacists, laboratories, and others to be on the same page when treating a patient. It can boost progress toward an outcome-driven, value-based payment system to replace the outdated and inefficient fee-for-service status quo, while also improving our quality measurement capabilities. With interoperability and access to clinical and claims data, we can accelerate medical research and give hospitals and physician offices real-time access to comparative effectiveness findings. An interoperable system can improve care to rural and underserved areas of the country through improved telehealth and remote patient monitoring. Wellness and prevention will also be enhanced through the better use of patient-generated data. This future is promising, exciting, and eminently attainable once we address some of the obstacles standing in our way. Last year, HLC, under the auspices of its National Dialogue for Healthcare Innovation initiative, brought together leaders from over 70 organizations representing government, industry, patients, employers, and academia. There we built consensus on how we can move closer to this desirable, data-driven future. Last month, we announced the consensus recommendations emerging from this effort, a number of which are relevant to today's discussion. On data interoperability, we believe that a firm date of December 31st, 2018 should be established by which health information is widely shared among electronic health record systems nationwide. We have the capability to reach this goal in the near term, not a decade from now. Progress towards this nationwide data infrastructure should be driven by private sector innovation, with emphasis placed on secure data sharing to protect patient privacy, common standards in governance, and a ban on data blocking. In addition, we believe that Congress and the administration must address physician self-referral laws and federal anti-kickback statutes, as well as civil monetary penalty laws. These fraud and abuse protections were built for a fee-for-service world, but today they often stand as barriers to the kind of collaboration and information sharing that is essential for value-based healthcare approaches and for improving patient care. Another barrier to data sharing is the multitude of diverse and often contradictory federal and state laws regulating health information that exist alongside the federal HIPAA regulations. We believe these national and state privacy laws and regulations should be harmonized to facilitate greater information sharing for the benefit of patients while still protecting their confidentiality. Members of the committee, I would like to close by applauding you for conducting this hearing and your focus on the issues that can genuinely transform and improve health care for every American. We can move faster, we can move more collaboratively across the spectrum of U.S. health care, and we can help more Americans maintain or improve their health better than we do today through data, information, and insights. We look forward to working with you toward our shared goals, and I will be happy to take your questions. Thank you.
Thank you, sir. Mr. Savage, you're recognized for 5 minutes.
Good afternoon, Chairman Hurd, Ranking Members Liu and Cartwright, and distinguished committee members. Thank you for the opportunity to testify today. I am Mark Savage, Director of Health IT at the National Partnership for Women and Families, a nonprofit, nonpartisan organization that for 45 years has worked to improve the lives of women and families. We are deeply invested in improving the value and experience of health care and ensuring that new models of delivery and payment help make consumers partners in their care with access to the right care at the right time. I'm delighted to be able to share today the values, experiences, and needs of patients and consumers who are using health information technology, such as online access and electronic data sharing with doctors to improve their health and care. The National Partnership leads the Consumer Partnership for eHealth Coalition and can speak broadly to the great opportunities that health IT presents and the obstacles that still make it difficult to realize its full potential. Health IT is the essential infrastructure for improving quality, care coordination, and value in our healthcare system today. It is a critical tool for engaging consumers who clearly recognize its value, according to a national survey we commissioned in 2014. We found that nearly 9 in 10 patients with online access to their health information use it. Notably, people who use online access frequently are much more likely than infrequent users to report that health IT motivates them to improve their health. Patients recognize that health IT is essential to improving their access to care as well as their access to their health information. They know what we know, that health IT helps patients and family caregivers communicate with their healthcare providers, share information, and manage their care, improves patients' knowledge of their health and empowers them to take charge of their care plans, allows patients to correct errors or outdated information in their medical records, such as a missing drug allergy, enables patients to share treatment outcomes, such as pain levels, functional status, and whether their health improved after the office visit, helps healthcare providers answer questions from patients by secure email, provide care with telehealth, and see the patients who need them most. Gives patients more control over how much personal medical information is shared and how it is used, and much, much more. Like electronic access in so many other parts of our lives, such as banking and retail, health IT enables real-time access to care and information and provides individuals with the convenience and control they need and expect in the 21st century. Health IT can also enhance patient trust and the privacy and security of patient data through encryption and other means. The country has seen a rapid increase in healthcare providers' adoption and use of health IT in recent years, but much work remains before the potential benefits reach all patients. We have an urgent imperative to break down barriers and continue the progress. First, That begins with removing barriers to health information. The national partnership runs the Get My Health Data campaign, and through it we have learned that many patients continue to face astonishing barriers to getting their digital health records from their healthcare providers. We need to change that by advancing policies and programs that promote patients' online access to and use of their health information. Second, we need to clarify privacy and security requirements for sharing health data because confusion persists about patients' access rights. That means, for example, adding proactive education initiatives about what HIPAA requires and what it does not, and encouraging mobile app developers and technology vendors to post their privacy policies and data sharing practices in standardized ways. Third, we need to enhance the usability of health information so that when patients access their medical data, they can understand and use it. For example, innovative apps could help patients organize their health information in ways they find most useful. And fourth, we need to bridge existing digital divides to help identify and reduce disparities in care. That means, for example, promoting online access to health information across diverse communities. And innovation in mobile apps can help. In sum, patients and consumers applaud the progress to date, and they need more. Patients have a unique vantage point, for they are at the center of the healthcare and information sharing we are all working to improve. Our goal must be to leverage health IT so it helps patients become real partners in their care and health. Only if we do that will we realize the full promise of health information technology. Thank you very much.
Thank you, Mr. Savage. We're going to keep going. We're expecting votes in about 10 to 15 minutes, so we're trying to get through as many members' questions as we can. And to kick us off this afternoon is the distinguished gentleman from North Carolina, Mr. Walker.
Thank you, Mr. Chairman. Appreciate the panel being here today and taking your time and being really a valuable resource for us. I'm married into the medical community. My wife is a family nurse practitioner at Wake Forest Baptist Medical Health Center. And every time I feel like I have, by osmosis, learned more medical knowledge after 23 years, she reminds me that I don't really have a good base of understanding. But this is something concerns. I remember even as a minister for 2 decades, sometimes trying to get information about a patient to family members or to others and trying to figure out how we can meet those needs, where sometimes there are problems to do that, even good laws. I also want to paint a picture here of some of the friends recently tagged along with a surgeon there at Moses Cone Hospital in Greensboro that has been so burdensome with some of the software and some of the regulation, it has impacted him negatively, as well as other physicians that have talked about this. So I want to address a couple of these issues. Maybe Mr. DeCrane, if I could start with you. You both mentioned in your testimony obstacles. You also mentioned the word barriers. Talk to me for just a minute, if you would, about what specifically are the obstacles and barriers to getting where this needs to go.
Well, I think some of the barriers and obstacles, Representative, are some of the things that I mentioned and some of the other folks here on the panel. First of all, there's a lot of activity underway around collaboration in the industry, but it's one that we think needs to be supported broadly. We have both private sector and combined private sector and government initiatives, things like the Commonwealth Alliance, the Sequoia Project. There's technical standards from committees like HL7 that are trying to push the ball forward to make these systems talk to themselves, to each other, a lot more adeptly and easily than they have historically. I think support for that, as exhibited by the ONC report that came out last year, to push us down a roadmap where those efforts can be channeled into a way that they ultimately come to a harmonized approach between the state regulations and laws and standards, federal laws, regulations and standards, and private sector initiative, really is one of the ways that we can make the most against some of the obstacles and barriers that exist today, where the systems don't have those standards, to make it easier for them to talk to one another.
Thank you for responding to that. Are you familiar with Press-Ganey scores? Some of you are familiar with those?
Patient satisfaction scores.
Exactly right. So I want to make sure that we're also being an advocate for the healthcare providers, that we don't put those guys in a bind. In fact, earlier this morning, we had a very passionate hearing, compassion, I should say, as well, as far as the heroin, the opiates, this, and we know sometimes patients can be very manipulative in this process. And can you take a moment to maybe, Dr. DeSalvo, and speak to that to make sure that we're also, as we move forward with this, we're not putting our providers in a more vulnerable position?
Thank you for the question, Congressman. You know, as a doctor, I know full well the challenges that making sure that you're being compassionate, but also being evidence-based in the practice of medicine. Wanted to touch on the patient access piece because you mentioned it, and it's so critically important. The electronic health information is theirs. They have the right to access it, and we have worked with the private sector to see that we're creating innovative ways that they have more ready access to that information so they can make their own care decisions, but also it can be available in the care setting. And as an example, just in the last few months, working with the Office of Civil Rights, who has the primary responsibility for HIPAA and access, put out some guidance directed at consumers so that they would know what they had the right to access. This is a common refrain that we hear from consumers, but also from docs who want to make sure that the information's getting out. In the space of opioids, as an example, we certainly want to make sure that we're doing everything to support clinicians on the front lines. My husband's an emergency medicine doctor, and so this is a very everyday occurrence for him. And the tools like PDMPs, the prescription drug monitoring programs, that are electronic in many states and have really made it easier for us to access information to make sure that we're appropriately giving opioids to people who have pain or need it, but also trying to help folks stay out of trouble. And we've been working with SAMHSA and with states to see that those are more, and then with the industry to see that those become more aligned within the electronic health records. So you don't have to go to another place and sign on. That's added burden.
Before my time expires, let me also look at this. Healthcare is certainly very important as we move forward in having the right perspective. As a member of Congress, we also have a financial fiscal responsibility as well. We spend more than $2,000 per patient than any other country in the world. Can we make a case out of this that this is something that can drive us to be more healthcare cost conscious as well? Mr. Quinn or Ms. Rich, either one of you would like to address that?
So I'll use as the example Intel's Connected Care program, where Intel is a large purchaser of healthcare on behalf of its 53,000 employees in the U.S., said how can we make our employees the healthiest in the country, retain them, and also try to save some money doing it. We've been very successful in the first two. The third has been more challenging, although there has been great progress there. The key to it, I would say, and this is also the key potentially for driving data sharing and information sharing in our broader healthcare system, is focusing on value-based care rather than fee-for-service. That was the engine that drove this, and we've seen a massive amount of actual use of this health information exchange because, of course, the technical pieces are there with the Sequoia project and building this, but also the incentives for using it are there for the healthcare providers.
Thank you, Mr. Quinn. Go back, Mr. Chairman.
Yeah, the plan is to go to Mr. Connolly, and then we'll go into recess to get to votes. And now I recognize the gentleman from Virginia, Mr. Connolly, for 5 minutes.
I thank the Chairman. I thank Mr. Liu and Mr. Cartwright for their gracious consideration. Thank you so much. I have 7 hearings in a day and a half, so I'm running back and forth. First of all, Mr. Quinn, thank you for sharing your story. Boy, could I relate to that. Both of my parents are in their 80s. And I've witnessed scenes where one is in the hospital in the emergency room and the other one is being asked to give the history, the medical history of whoever's. I'm thinking, what could go wrong with this scenario? You know, thank God they're both alert and have mental acuity, but, you know, memory sometimes fails us in moments of stress. And it's hardly an ideal system. And surely technology exists that would allow us to have a comprehensive picture of the patient in question without relying on human memory and such. So I really related to what you had to say, and I hope your dad's doing well. Dr. DeSalvo, picking up on Mr. Quinn's narrative, according to HHS's 2016 report to Congress on the adoption of health IT, your agency found that 97% of hospitals and 74% of physicians possessed a certified electronic health record system. But only 76% of hospitals and 42% of physicians with electronic health record systems were sharing the information for the coordination of care. Why that big gap?
Well, thank you for the question, and I certainly identify with Mr. Quinn also, both as a doctor who takes care of those kinds of patients, but also because of family members as well. And so, as I said in my opening, it's pretty personal to all of us to see that the data is moving. I think the good news story in the data that you present is that over the course of the last many years, we have dramatically increased not just adoption, but the opportunity to move and share data. So those are snapshot numbers, but if you look back at the trajectory, every year it improves, both with doctors' offices and hospitals. We're not where we all want to be yet, but we are making progress. There are areas like the National Capital Region where health information exchanges like CRISP make that data available, such that if somebody arrives in an emergency room, their primary care doc will get a ping and be able to have the opportunity to send that med list or the problem list so that we'll actually know more about the person in the ER. And there are even more exciting advances happening, like in Mississippi, where the state of Mississippi has been working with local vendors to see that all of the long-term data from their Medicaid program is available to the doctors in the University of Mississippi Medical Center, so that when someone arrives, you have that picture like you mentioned.
No, you mentioned Chris, but I mean, doesn't that require a voluntary decision to participate?
So you are touching on the challenge that's emerged since we've been adopting electronic health records and moving to a digitized system, and that is that state laws vary.
Yeah.
And so there's some need to harmonize that.
Right, and that's a particular challenge here in the National Capital Region, since we have 3 jurisdictions with 3 different political cultures and sets of laws and so forth. And I have actually encountered that, where Maryland has one set of standards on this kind of communication, and Virginia has another, and we're not always talking what could go wrong with someone's health. I mean, you could jeopardize someone's health without intending to. Now, do we need, from your point of view, and I welcome Ms. Rich as well, or anyone else, but I mean, is this a case where, frankly, we do need to look at some federal legislation? I mean, we regulate blood supply for safety. Well, electronic record keeping isn't just a nice thing to have. In the digital age, it may be very critical to someone's health and the care they get, especially in an emergent situation.
In the short run, we have been working with the Office of the National Coordinator with the National Governors Association on developing a toolkit so the states themselves can harmonize their privacy expectations, so that won't be an unnatural impediment to information flow. Over the long term, clearly the health IT landscape has changed a lot since HITECH was passed in 2009. You know, we were on iOS 3 then, and now we're up to 6, just as one example, but apps and the cloud computing have really evolved. So we certainly are leveraging all the opportunities that we have at ONC and our partners at Office of Civil Rights and in other agencies to see that we're protecting consumers and that data is going to flow. But there are areas where we know that there may be some opportunity, like information blocking, where we would need some additional support.
Thank you so much for this fascinating conversation. Again, Mr. Chairman, thank you.
Sure. Votes have been called. The committee stands in recess until immediately following votes.